in the United States of America. Through our webinar research and field-based projects, we aim to create space where learning, shared experience, and practical solutions come together. So once again, you are welcome to the GET webinar series, January edition 2026. And today we'll be focusing on strengthening infection prevention and control, that's IPC and WASH, for health emergency preparedness and response. If you are just joining us, please put your name and wherever you're joining from in the chat box. For instance, my name is Faith. I'm joining from Nigeria. So we understand that across our communities, we continue to see how emergencies, either disease outbreak, climate-related events, or humanitarian crisis hit the hardest, where wash system and facility preparedness are weak. Therefore, it is important that water sanitation, hygiene, health facilities readiness is strong. So this will make our response faster, to make our response safer, and even far more efficient. When the response are not fast, when WASH is not in place, when IPC is not in place, it is certain that the consequence can be devastating. So today, we are here to discuss practical lessons, real-world experiences, and what works, especially at the community level, where response truly begins. Therefore, GET is organizing this webinar to convey international organization, technical experts, policymakers, implementers, and every stakeholder at each level to examine how IPC and WASH can be strengthened as a core pillars of health emergency preparedness and response. Before we proceed, I would like to mention a few housekeeping rules. Like I said earlier, please introduce yourself wherever you're joining us from in the chat box. Also, please use the Q&A session to take note of your questions, which will be attended to after the presentations of our speakers. This session is being recorded and will be uploaded on our YouTube channel at Get Africa after the webinar. Also, certificates of participation will be issued to every registered participant. So if you are joining using the anonymous link, you can go and register via the registration link. The registration link will be posted in the chat. So use that link to register so you can get your certificate of participation. With that being said, it's my pleasure to now dive into our speakers we have for the day. We have our lineups of speakers, and I'll be mentioning them now. We have Dr. Amuda, rather. I apologize if I pronounced that wrongly. Usman Noshin. We have Dr. Mary Ashinyo. We have James Corrado Masakio. And we have Dr. Damlola Adeni. Now, I would like to invite our first speaker for the day, who will be speaking on operationalizing infection prevention and control in health emergencies. And before I go ahead, I would like to read Dr. Mahmoud Amuda's biography. Dr. Mahmoud has over 18 years of experience as hospital epidemiologist and infection preventionist in both private and governmental healthcare systems, and with the UN responding to global pandemics. As the regional director of infection prevention and control in the large international multi-hospitals in Egypt and Saudi Arabia, he has worked as Director of Quality and Patient Safety in one of the tertiary teaching institutes in MOH Egypt. His experiences include working as IPC surveyor with Saudi Central Board of Accreditation of Healthcare Institutes and IPC chapter leader, achieving different accreditations such as GCI, CBA, HI, Canadian, GAHA, and TEMOS Internationally, he was deployed as an IPC consultant and IPC lead with WHO organization at the headquarters, responding to different pandemics and outbreaks such as Ebola in West Africa and in Lassa fever outbreak in Nigeria. With WHO EMRO in response to the COVID-19 pandemic in Eastern Mediterranean region, with special focus on strengthening IPC implementation in vulnerable countries such as Afghanistan, Libya and Palestine, Somalia, and Yemen. Mahmoud earned a bachelor's degree in pharmaceutical science from the University of Alexandria, Egypt, and a postgrad diploma in global strategies of hospital hygiene from Claude Bernard Lyon University, France School of Medicine. In 2016, he achieved CIC certification in infection control and epidemiology. And in 2018, he got his master's degree in business administration, MBA from Arab Academy of Science, Technology, and Maritime Transport. Mahmoud is an active member of APIC, ISQA, and the Global Outbreak Alert and Response. He had participated in developing and reviewing many national IPC guidelines in different countries in EMRO and Africa regions. Mahmoud is currently working as Health System Officer, IPC Country Engagement, Health Emergency Program at the World Health Organization, headquartered Geneva. That was a long read. I apologize for that. I will now hand over the floor to Mahmoud. Thank you, and over to you.
Thank you so much, Faith, and thank you so much for this comprehensive introduction. And pleasure to be with you today, and I'm going to share my screen right away. And welcome to all our participants today. Let me share now. Please confirm that you can see my screen.
Yes, we can.
Okay. I'm sorry. Okay. So as Fis mentioned that today we are going to speak about the operationalizing of infection prevention control and health emergencies, global guidance and country experience. I'm going also to focus on the WHO IPC framework and toolkit for outbreak preparedness, readiness, and response. Along with the recently published implementation manual and also the IPC and WASH hero a checklist. So without any further ado, and apologies for the delayness, so what are the types of the public health emergencies? Could be natural disaster, conflict, and chemical or infectious outbreak. And our mandate as WHO to focus on the, I'm going to speak today about the infectious outbreak and how we can strengthening the IPC and WASH systems at the national and subnational levels, along with the health facility levels. So, and as an overview about my presentation today, it should cover the why IPC system must be available and strengthening in place before the emergencies and before the outbreak, what happens when the IPC system is not exist, how the countries can strengthen and operationalize the IPC system, what the key WHO guidance and tool to support this work, and how IPC and WASH should come together and integrated through a practical operational tools and during the response. So I'd like to start with the IPC challenges during the public health emergencies and lesson learned from different pandemics and outbreaks, whatever was Marburg or Ebola or COVID or measles. We have seen different outbreak and pandemics through the past years. And globally, the IPC, one of the top 5 challenge as capacity. If you have a look on the global IHR or international health regulation, state parties self-reporting tool, which shortly we call it the SPAR tool, we find that IPC capacities is among the top 5 challenging capacities with 55% globally. And if we look at African context, we will find it's only 42, which has been that we have a limited capacities for IPC in African context. C9, for your background, C9 is the IPC capacities, which include the IPC programs, IPC surveillance, and the safe environment which must be exist. So it's a 3 indicator, and according to IHR or the International Health Regulation, it must be there to strengthen the IPC country capacities to response to outbreak and health emergencies. As I mentioned, 42.5 the overall IPC capacities in African context. So from the previous outbreaks, we know that the key operational challenge for IPC could be rapidly evolving situations, unpredictable outbreak patterns and outcome, inadequate search capacity and sources, lack of shortage of healthcare workers, shortage of supplies, health system disruption, poor infrastructure, including, of course, wash services and waste management, inadequate IPC in the communities as well, and coordination and challenge across the response pillars, implementing partners, different level or different challenge across the health systems. Insufficient data and on the infections of healthcare workers. So there is consequences, and there is consequences of the IPC challenging situations, like, as I mentioned, healthcare worker infection, which may lead to loss of the skilled staff, absenteeism, collapse of the health deliveries as well, and also we see this a lot in different outbreaks, that the implications of the outbreak within the health facility and beyond. We saw this in different outbreaks, that the communicable disease will convert it to nosocomial transmission, nosocomial infection, and later on the amplification in the community and beyond the community could be border crossing infection. We saw this in different outbreak and different countries. Also, as I mentioned, disruptions of essential health services. This could be also as one of the implications. And also we saw different and fragmented response. All that to say that IPC must be there beyond the start of the crisis or start of the outbreak. So we need to build our capacities. We need to strengthen it through the proper preparedness, readiness, to have an effective response during the crisis. And this could not be built overnight. So that's why we need to be ready. So here our problem, as I mentioned, that IPC and public health community we need to learn from the previous outbreak and pandemics to better prepare for the future crisis. So what we have as a global WHO document technical guidance, we have the global IPC strategies. We have the global health emergency coordination mechanism and the architecture, which I'm going to speak about it in the second minute. We need sustained resources. We need a political commitment and leadership. This is also most important to be in place. So without the political commitment and leadership, we cannot build strong IPC system ready to respond to different outbreaks. So WHO developed the HABER framework, which is shorted to health emergencies, prevention, preparedness, and response and resilience, within which have five pillars: collaborative surveillance, access to countermeasure, community protection, emergency coordination, safe and scalable care. And within the safe and scalable care, IPC positioned in this core component to protect healthcare worker and to prevent hostile acquired infections. We have different tools, we have different guidance. We have the framework and toolkit for IPC in outbreak preparedness, readiness, and response. And we have also the implementation manual, which is offer step by step how we can achieve. So the framework in general focus on what we need to do, who's responsible for what, but while the implementation manual will explain the country experience and case studies, step-by-step approach how to implement the framework. So here in this presentation, I also put the links for this. And also we have different tools at the national, subnational level, and also disease-specific health facility levels as well. So from the national, subnational level, we have the HERO checklist, which is the health emergency readiness for response operations, which I'm going to speak in a while on this in details. So our goal for outbreak preparedness and readiness and response is to reduce the transmission of healthcare associated infection, to enhance the safety of the staff, patient, and also visitors, to enhance ability of the organization or health facility to respond efficiently and adequately to the outbreak, to lower or reduce the risk of its amplifying to the outbreak. So in public health emergencies, what changes about the IPC? We know that IPC, we focus on the standard precautions and the transmission-based precautions. While during public health emergency, we need to shift the focus and the scope from the prevention to the content of the outbreak or the pathogens within the health facility and the community settings, like, for example, schools or shelters. We need to intensify IPC protocols. We need to have a tailored SOPs in place for this particular disease according to the mode of transmissions. We need to prioritize the early recognition and the isolation of the suspected cases. So we need to strengthen the screening, triage, and isolation notification. We need to enhance the environmental control measures as well and services. We need to increase the frequency of the cleaning, disinfections. And the same times, we need to be ready and planned for surge capacity and operation adaptation. So HR, or the human resource factor, is important. We need to have adequate infrastructure, financial support, of course, above all, to implement the needed interventions. We need to have very responsive supply chain system in place. We need to adopt the IPC guidelines, as I mentioned, to this particular priority threat or pathogens based on the outbreak. And also, we need to strengthen the intersectoral collaboration, coordination, communication. So, and this is, I think, in my opinion, one of the most important capability the countries need to have, the strong coordination system. We need to coordinate among our partners, even among the different departments within the Ministry of Health or the national authority, to contain and to prepare for the outbreak. So, as I mentioned, I'm going to focus on the framework and toolkit for IPC during the outbreak. The goal from this document is to prevention and control of communicable disease and with the community outbreak potential, which may be amplified in the healthcare facility, as I mentioned. So we have one at the national, subnational level, and one framework at health facility level. So the framework of actions for strengthening the IPC outbreak preparedness, readiness, and response toolkit is to provide resources to assess the development of local contingency plan and actions plans as well. In this framework, you will find different three main phases, and what activities and intervention entails in each phase, and what interventions need to be done and need to be in place on these phases. Phases about the preparedness, which is more strategic interventions and activities with time frame from 2 years to up to 6 months in advance before identifying a public health threat. Readiness phase is up to 6 months in advance of defined a threat. And in every phase, and of course, the response phase is the emergency actions are required in the response, and what actions, interventions need to be taken and need to be in place in every phases. So the key IPC actions at the national and facility level need to be there. Of course, I need to evaluate and have baseline overview about my capacity at the national level or even at the facility level. So also I need the IPC preparedness and response plan to be there. We need the documentation. What our plans in case I have the priority public health threat, who's going to do what and where. I need the SOPs or the guidance for this particular public health threat or pathogens identified. We need to train the healthcare workers. And this is also one of the identified gaps in different outbreaks, especially if the country has no previous experience in this disease. The gap in knowledge among healthcare workers, and which is have a serious ramifications or amplifications even on the healthcare workers themselves. The could be infected, and God forbid, also they may be died due to the infection as well. And as a sequence of this, of course, you will collapse the health system delivery as well. So what other activities and interventions need or actions need to be there? The surveillance and reporting program. It's very important to track. It's very important to identify, and most important, and here I'm speaking about the surveillance as a system approach. So the required resources, the trained manpower, the everything, the reporting chains, and so on. Also, one of the key activities is to have communication strategies. You need to disseminate the proper IPC knowledge and information to both the healthcare workers and also to the communities. For example, and we saw this at time of COVID that the community encouraged to wear mask in the crowded places or in poor ventilation situations. So it's very important to disseminate the IPC measure to the community as well. Also, in addition to IPC surge capacity planning, what if the situation evolved, what resources will need, and so on. As I mentioned, also one of the key activities, the outbreak task force, or we can say the coordination mechanism. We need to map our partners in the country. We need to know who's doing what and where, so we'll avoid duplication of effort or even wasting efforts, which we've seen in different situations. Goes with that also the partners mapping and networking, and also um, um, the last actions we or this is also need to be there in the preparedness and readiness activities, which is testing our capability and testing our system. This could be done through the simulation exercise with different modalities. It's very important to test our capacities before the crisis and before the outbreak. um, I don't want to provide, uh, to repeat what I said, but the evaluation of the IPC capacities, we have different WHO developed different tools for this. In the preparedness phase, for example, we have the IPCAT tool to assess the national capacities. In the readiness phase, we have the HERO checklist, which I'm going to speak about it in a minute. And at health facility, we have the IPCAF tool, we have the minimum requirement assessment tool, and for different levels and categories of health facility, primary and secondary and tertiary health facilities. We have different tools to assess the readiness of the health facility as well. In addition, also, as I mentioned, to the disease-specific rapid assessment tools, we have one for Ebola and Marburg, for example, and also for mpox. Toolkits, which is available resources, you will find it in details in the framework. And as I mentioned in the beginning, that we have also recently developed the implementation manual, which speak about each action step by step, what the barriers and how to overcome it, the country examples and case studies, practical adapted tools, linked to all the resources. For example, if you want to start a simulation exercise, you will find step by step how to conduct it, what the different modalities, what the templates needed, for example, for to develop a national action plan or whatever you will need. You will find these resources attached. For the IPC and WASH Hero Cap tool, in general, it's self-assessment tool to strengthen and identifying gaps among the national, subnational capabilities. So it's structured in alignment or based on the framework and toolkit to help the health official to evaluate the functionality of IPC readiness capabilities, and also it will guide you to develop the improvement plan. So the specific objective for this tool to assess the existing readiness capabilities, to identify gap, as I mentioned, and to develop the improvement plan. To whom? Who is the target audience? Who can use it? The government, national and subnational authorities, for example, Ministry of Health, the national CDC, if exists in the country, IPC and WASH focal point and public health professional. The assessment could be done either done as a self-assessment by the government or the IPC and WASH focal points, or could be done jointly with the implementing partners as well. As I mentioned, the HERO checklist, the assessment tool, it's structured based on the framework and identified 6 core capabilities need to be there with 23 sub-capabilities based on the needed actions and interventions. For example, as I mentioned, the coordination, the partners mapping, the readiness plan, contingency plans, and also the stockpile systems. So at the time of the response, you need very responsive, and you need to very responsive stockpile system, and you need to test it ahead of the crisis or the head of the outbreak. You need to test it. You need to experience your capabilities to response, and this is important, particularly as part of the readiness phase. Training of healthcare workers, you need to have curriculum in place. You need to have active training program. And also, you need to be ready with different communication messages and material needed to educate the community and also the healthcare workers. And here we need to consider also the language barrier. So if you are IPC national focal point, my advice not to bring from the internet the English versions of the boosters or technical guidance and copy paste it, but you need to adapt it and consider the using it and translated it into the local language, which is very important. IPC assessment at health facility at time of the outbreak, and this is also one of the benefit of this tool, the HERO checklist, that the scenario that when a country identifies public health threat or identifying a threat, particular threat for example, Ebola or Marburg, the country will not exhaust the whole health systems, but need to think to dedicate and plan dedicate healthcare facilities to be the first health facility to handle this threat. So according to the geographical risk assessment, the population risk assessment, I need to figure out which facilities going to respond immediately if the outbreak happens. And if I identify this health facility, I need to assess its readiness to response. So that's important also. Sub-capability mentioned in the checklist that you need to, for example, to complete the assessment of this health facility in advance to or before the outbreak. And we also provide guidance on what tools could be used and what target need to be achieved. So when the health authority or the the decision maker at Ministry of Health ask you as an IPC focal person, are we ready to respond? How many health facilities ready in terms of IPC and WASH? You need to be proactive. You need to assess your facilities. You need to have figures to respond to this question. This is screenshots from the checklist. You can see here the scoring system. We have from 1 to 5. From 0 to 20%, you could score it 1, and so on. It's 20% interval between each score, and also score 1 if the capacity or sub-capability is not exist. 2 when it's under development, it's not yet achieved. When the sub-capability at national level with need to support in terms of resources, you can score 3, which is partially ready. Mostly ready when you have this capacity available or exist or implemented or in place at national, subnational level, and to some targeted health facilities as well. 5, when score 5, when the the sub-capability implemented at all levels. Okay. So just to remind you that how to use this tool, we need to identify, we need to assess, we need to evaluate, we need to develop the action plan and conduct a follow-up assessment as well, and integrate our findings with other department and other colleagues within the national authority, and to inform the readiness plan about the baseline. So many countries use the HERO checklist as baseline to assess the national, subnational capabilities, and based on the identified gaps, they either adopt the framework to national framework, the WHO framework to national framework, or use this to write a situation analysis to highlight the gaps and needed action for improvement. I would like to thank all the countries participating in the pilot testing before and use this checklist, like Rwanda, Sierra Leone, Namibia, Ethiopia, and Ukraine. This checklist has been published, and you can find it in the website. I also left the link for this tool in the presentation. Thank you so much. I'm afraid that I exceeded the time, and thank you once again, and back to you, Faith.
Thank you very much, Mohammed, for that clear and insightful presentation. You mentioned a few things, and I would like to re-mention them. You mentioned the three activities prioritization of the IPC outbreak framework and emergency preparedness. You mentioned preparedness, you mentioned readiness, and you also mentioned response. So thank you so much for that beautiful presentation. And so our participants are asking if the presentation slides will be shared. With the permission of our speakers, yes, the presentation slides will be shared to every registered participant alongside their certificate of participation. So right now, it's my pleasure to introduce our next speaker for the day, Nashin Usman, who will be speaking on strengthening WASH systems in health emergency with a focus on preparedness and response frameworks. I would like to read our biography briefly. Pardon me. Nushin Usman is a WASH expert with over 13 years of experience, specializing in water, sanitation, and hygiene and environmental health in public health emergencies, with a strong focus on outbreak preparedness, response, and recovery in fragile, conflict-affected settings such as Pakistan, Yemen, Afghanistan. I work in supporting national health authorities and emergency response to prevent, detect, and response to infectious disease threats. Driven by a desire for advanced knowledge and global perspective, she pursued a master's degree in water resource management. Her commitment to excellence was recognized as she became an Australia Award Scholar, furthering her expertise in water quality and environmental management. She currently serves as a technical officer for WASH within WHO Health Emergencies Program at headquarters, where she leads and supports emergency-oriented normative and operational work related to high-risk infectious disease, including cholera, dengue, mpox, and Ebola. Our role includes the development of global technical guidance, standard operating procedures, assessment tools, and operational frameworks that strengthen WASH and IPC readiness in humanitarian and outbreak settings. She provides technical support to WHO regional and country offices and the Ministry of Health, with a strong emphasis on contextualizing global guidance for implementation during active emergencies. Nasrin has extensive experience supporting public health emergency responses through field surge deployment, remote operational support, and coordination with health and WASH clusters, particularly in cholera outbreaks in displacement and urban emergency settings. Our work strengthens water quality surveillance, environmental health risk management, and emergency wash service delivery to reduce disease transmission during crises. She also led environmental and social safeguards for World Bank funded emergency projects, integrating GBV risk mitigation, stakeholder engagement, and accountability mechanism. With a strong focus on climate health nexus, she promotes climate resilient, sustainable WASH approaches in emergency preparedness and response. She also plays a key role in strengthening interagency emergency collaboration, including the WHO UNICEF WASH in public health emergencies platform, where she supports coordination, lead technical exchange on emerging risk, and contribute to regional and global emerging capacity building initiative. Pardon me for that long read. And I would also like to mention that if you have questions, please direct them to the Q&A session, and it will be addressed after the presentations by our speakers. Thank you so much. You now have the floor, Roshini Usman. Thank you.
Thank you so much. Yeah, that was a long introduction. Sorry for that. My name is Roshini Usman, and I work with WHO Health Emergencies Program based in Geneva. So my presentation is focused on WASH and public health emergencies. I work with IPC Boston, and my colleague Mahmoud has already set the base, and he shared some of the integrated IPC and WASH tools. So my presentation focus entirely on WASH and public health emergencies and how WASH contributes, and it has a role in different outbreaks in prevention, preventative phase, preparedness and response, and how the integration with IPC supports the safe and scalable care and community protection in public health emergencies. So the main objective is that, I will highlight some of the WASH challenges that we are facing in the current crisis. Also, why the integration of IPC and WASH is essential, and then share some of the guidance tools and resources from WHO side. So just setting the base that why WASH is important, we are currently observing that there are 20 countries you can see on the map have humanitarian crisis, which accounts for 82% of the people in need, in humanitarian need, and 77% of these populations are forcibly displaced, which ultimately leads to a lot of public health risks. We are facing and observing a lot of multiple cholera outbreaks, waterborne diseases outbreaks, as well as other infectious disease outbreaks in these settings. And why we are mentioning these settings? Because they have limited resources. Resource scarcity is the biggest problem. Forcible displaced population further increasing the waterborne diseases risk because they do have limited WASH services availability. I will give here example of DRC, where 60% of the population, entire population, lacks access to the safe drinking water. And in IDP's settings, only 15% have access to some of the sanitation services, and usually it's below the fair standards that we are providing resources. On top of that, all these displaced communities have psychosocial stress because of displacement, the trauma due to conflicts. All these conditions and enabling are factors that are contributing to the risk of spreading the infectious diseases and waterborne diseases. So the first risk that I would highlight here is cholera. You can see it in the slide that the data that how it is spreading to different countries. So we started from 30 in 2023. Now the 33 countries are reporting cholera cases. And we have seen that in these countries, if you look into the 2024 figures, there is 6.7% of the surge in number of cases from 2023, and 25.7% in increase in number of deaths. So there are multiple factors, and then the continued rise in cholera cases has been reported. in 2025 as well. And these, if you can see, there are 3 countries in acute crisis: Angola, DRC, and Sudan. And Sudan and DRC are further, they are affected by climate related events, by the conflict, as well as if you can see from the figures that the major contributing factor is lack of safe water, sanitation, and hygiene services availability. As I mentioned, that there are other countries. We have seen now currently the Mozambique is affected by the seasonal flooding or climate-related events. So there is displacement. The current cases of cholera are reported from these areas. Also, additionally, from Sudan, there are since 2024, the outbreak is ongoing, and there are multiple factors. Lack of water and sanitation is one factor, but urgent displacement, and these displaced communities do not have access to safe water, sanitation, and hygiene, which resulted in multiple outbreaks in these locations. And it was directed, and also the attacks on WASH infrastructure or the water infrastructure or electric grid station resulted in the spikes of cholera outbreaks. So all these multiple situations are contributing factors for cholera outbreaks. Another public health risk I would highlight that has a link with the climate, with WASH is natural disasters and climate change. As I've mentioned in my first slide, that 123 million IDPs and refugees have been reported in 2025. And to WHO, this is the latest report that we have seen, that 14.4 million of dengue cases have been reported in 2024. So you can see and access the resource in the slide. And dengue, if you see that all these mosquito-borne diseases have very close linkages with WASH, including water resource reductions and solid waste management. Now coming to the main, all these services, what is the status of our health facilities? Whether these health facilities are able to provide healthcare services to the communities affected by conflicts, by outbreaks, by these climate-related events. So if we see the latest global report, which was published in 2025 on WASH in healthcare facilities using the GMP data of 2024, of facilities serving 742 million people have no access to basic water. 660 million people using these facilities do not have toilets. And the healthcare facilities serving 722 million people are without hygiene services. So what do we say? Do we call it a health facility? I don't think so. It's a health facility, because if there are no WASH services, we cannot operate and provide qualitative healthcare services in these facilities. Fragile context further the situation is worse than the stable countries. 19% of the health facilities have only basic sanitation, whereas 37% are with basic water services, which further exacerbates the delivery of healthcare services to the communities. Coming back to Mahmoud, he alluded into the fact that how the disease is spread from health facilities, and then how we can prevent it in the communities. So this is the concept of IPC and WASH in the communities that we have seen in different outbreaks, like in Ebola, in COVID-19. We have seen it in mpox. That the community protection is a key pillar. Besides the safe and scalable care, which is within the health facilities. So we have to make sure that these WASH and IPC integrated services are available within the communities. There are overlapping areas that we see between WASH and IPC, but we have to make sure through coordinated efforts by different stakeholders that these services are available to the communities. And in this way, our example is IPC ring approach, which has WASH linkages. Home-based care for mpox is another example that provides integrated IPC and WASH services within the communities. So to make sure and how we can see it is through integrated approach. So if we integrate IPC and WASH together from planning till to end of monitoring and through resources, this would enable us to provide qualitative and equitable WASH services to the communities as well as within the healthcare facilities. And it should happen at different stages through in the preparedness, through in the technical resources that we are developing. As Mahmoud has already mentioned about the national level capacities and the health care facilities, integrated IPC and WASH checklist for the healthcare facilities to assess the services, to see what are these services that are complementing each other, and develop improvement plans for the gaps that has been identified. Another pillar that besides the community protection is the safe and scalable care, and it's part of the HEPR, which Mahmoud has presented, is the Health Emergency Preparedness, Response and Resilience framework that has one pillar, safe and scalable care, and under that, protection of healthcare workers and patients through IPC and WASH interventions is a key pillar of this component and area of work to ensure that the healthcare services are provided with quality and improve our services availability. How we make these interventions and these frameworks and these technical areas into action. So we have to make sure that whatever the guidelines that we are developing at the global level are operationalized and contextualized according to the national needs and context. So on the global level, we have guidance available and strategies for disease-specific. I will give example of mpox here, that we have developed strategic guidance on how to develop integrated IPC and WASH strategy for control. So the first step is to have norms and standards available for these different technical and disease-specific areas. Then strengthen implementation of IPC and WASH. That is through assessment tools to identify data collection, availability of SOPs, as well as resources and research capacity within the healthcare facilities, as well as in the response and preparedness phase. And then when we use the assessment tools, that would help us to find available capacities that are available, and what are the gaps, and then build the capacities according to the identified needs. So there are different resources available for different areas and thematic areas, both on IPC and WASH, which I will explain in a while what are available for WASH as well. So these are some of the guidance, like how we, there are three areas. Like first is infrastructure, as Mahmoud mentioned in his presentation. Second is capacities, and then third is data collection, monitoring, etc. So first, enhancing infrastructure, how we do it. We have standards available. Essential environmental health standards are available. We have standards for waste management, as well as we have also contextualized these standards into different settings. Like I've given the example of Gaza, where we had the standards available, but the situation was dire, and it was very difficult to implement the sphere standards or these global available standards. So we have developed this guidance to contextualize it and to provide alternate resources, alternative measures for WASH and IPC when these minimum and sphere standards cannot be implemented. So in this way, and also these standards can be used to enhance infrastructure and facilities through a coordinated way. This is a tool, WashFit. If you have also heard it in our presentation earlier, that this is a facility risk-based management tool, which involves monitoring, planning, assessment, improvement within the health facility identified through the assessments, and then monitoring it through the technical working group established for WASH fit implementation. Currently, as you know, that the WASH in healthcare facilities involves 8 steps to improve. So these ads and 100 countries are reporting on this WASH tracker, which is I will provide. I have provided the link in these slides. These 100 countries are reporting on how they are implementing and improving the WASH in healthcare facilities. And this tool has been used even in the emergency context. I will give example of Ukraine, Yemen, Iraq, and we have used the light version of the WASH fit in Gaza as well as in Myanmar in the acute emergency phase. So this tool can be adopted also to the local context using the existing available information. And this tool, the benefit of this tool is that it helps in sustainable environmental and sustainability and climate resilience by ensuring that if these indicators are integrated, it can improve IPC measures by making sure that the WASH services like water, sanitation, hygiene, environmental cleaning, and waste management services are available. On top of that, there is also electricity component because most of these health facilities, we have seen electricity is the main driver of provision of these services in the facility, and these facilities are relying on unsustainable electrification resources. So to make sure that if we use these tools, this will help us to identify the key resources. And then ultimately it helps in provision of quality healthcare service delivery. I won't go into the details because it has already been presented. The strengthen the capacities, like, the WASH professional, IPC professionals in integrated way. We have the short WHO courses available on WASH fit, how to use WASH fit in acute phases, and this is a short version. Anyone can self-paced course to use it. And then the search capacity to identify through all the checklists that we have mentioned earlier. Hero Cap checklist, as well as rapid assessment tool for health facilities, and WASH fit, and use these data collection tools to develop improvement plans and make sure that monitoring and supervision is happening throughout the firm. Partnerships and networks are very important component of the response, because without partnerships, it's very difficult to achieve the outcomes and the desired goals for controlling and preventing outbreaks. So we have these different networks, IPC Technical Working Group, WASH in Public Health Emergencies Network at global level. We have GO-ON and also Africa CDC at the regional level. So these are different partnerships that we have established over the period of time to share our practices, recommendations, updated tools, and resources with partners. Here it's an example of how we did it in mpox. So the global strategic guidance was developed where IPC and WASH was presented in a community protection pillar, safe and scalable pillar, and also we provided technical support to other pillars such as point of entry, safe and dignified burials, and mass vaccination. And these are different technical resources that are developed for each thematic area and also different type of settings. And through partnerships, we try to operationalize these tools and also disseminated it through different channels like EpiVin, ECHO, and country-specific webinars. So by looking into the opportunities, like, what could be the opportunities, that how we integrate from emergency to development phase, because we have to make sure this is the learning that we have. We experience lessons learned from the previous outbreaks and emergencies, that we have to make sure that whatever the IPC interventions or WASH interventions are done by partners, by WHO, by Ministry of Health, by different stakeholders in emergency response, have to be sustained even in the development phase. And And we have to look into the broader approach by using these different frameworks like HEPR, pandemic accord, as well as the available toolkits that we have mentioned. So these are different WASH tools for communities, for healthcare facilities that we can use in preparedness phase, for capacity building, in response phase, according to the needs of the countries. So I will hand over to you. Thanks for giving us the opportunity. Over to you, President Lance.
Thank you very much, Noshin, for that excellent presentation. You mentioned a few things. You spoke about how the integration of IPC and WASH is important, which it enables the countries to provide a safe and scalable care to their community members' protection through development of norms, standards, partnership, and promoting research and capacity strengthening. You also mentioned the WASH Fit framework, which includes the establishment and training of the team. It includes the assessing the facility, identifying and prioritizing areas for improvement, develop an improvement plan and take action, and lastly, monitor, review, adapt, and improve. Thank you so much. That was very insightful. Now that we've heard about the global guidance and framework, our next session will now shift us to the implementation realities. And unfortunately, we do not have our next speaker on the call due to unforeseen circumstances. Or Dr. Ashinyo, if you're on the call, please, could you signify? Apparently, we do not have our next speaker, Dr. Mary Ashinyo, on the call, which moves us to the next speaker for the day in person of sorry, a minute. James Kurad Masikio. I apologize if I pronounced that wrongly. He will be speaking on strengthening community level WASH and health facility readiness for effective emergency preparedness and response. I'll be reading his biography shortly, but before that, if you're just joining us, welcome to the GET webinar series, January edition 2026. Kindly put your name and wherever you're joining from in the chat box. Also, direct your questions for individual speakers to the Q&A session. It will be attended to at the end of the presentations. Now, I'll be reading the biography of our next speaker, James. James currently works with UNICEF as a water, sanitation, and hygiene WASH specialist based in Salam, Tanzania. He has worked for over 20 years in the WASH sector, 15 years of which has been with UNICEF, including Liberia, Mozambique, Sierra Leone, and Yemen, and now in Tanzania, implementing climate resilient, gender responsive, and equity-focused WASH programs. Korad also works with other WASH sector organizations, Oxfam Concern, World Vision in Kenya, South Sudan, and Sudan. You now have the floor, James. Thank you.
Please confirm you can hear me. Can you hear me?
Absolutely. Yes, we can.
Okay. Good afternoon, good morning. From wherever you're joining from. So I'll just go right into this and okay, fine. So for this session, I'll just highlight because I will actually be talking about on strengthening community level WASH and health facility readiness for effective emergency preparedness and response. And I will frame my presentation more around Tanzania, in as much as I'll be bringing in examples from Sierra Leone, Liberia, especially around Ebola, since I was also part of the response in 2023-24. And in terms of objectives, I will just highlight the community-led WASH readiness and response. I'll also discuss the impact of poor WASH in healthcare facilities capacity to contain emergencies. especially health emergencies, understand key activities and implement pathways for WASH and health emergencies, and highlight actionable recommendations to support the integration of IPC and WASH in health emergencies. Just by providing a few data, the latest JMP report is noting that about 1.1 billion people lack access to basic water in healthcare facilities, 3.0 billion lacking access to basic sanitation in healthcare facilities, 1.7 also without improved hygiene services. And of course, in terms of data, some countries still do not have data, and even some indicators also still do not have enough data. As you can see, we have 78% data, in terms of access to water in 2022, and 57% access to basic sanitation in 2022. But of course, actually not sanitation, hygiene, sorry. We don't, there is insufficient data for sanitation, and if you look at this data, according to the JMP, most of these that are not accessing water in healthcare facilities live in, mainly in 5 countries. They have noted those are mostly in Ethiopia, Nigeria, Pakistan, and Russia and the DRC. So for Tanzania, I think I'll just, because I'm looking at Africa generally, I'll just skip this slide. But just wanted to highlight, the status of the sanitation and the water in Tanzania. But I'll just skip this one and go to, our implementation approach. So when it comes to WASH, we're looking at, we're really looking at the SDG 6, 6.1, looking at water, with a goal of achieving universal access to achieving universal equitable access to safe and affordable drinking water for all by 2030, and achieving access to adequate and equitable sanitation and hygiene for all, and end open defecation, paying special attention to the needs of women and girls by 2030. So for UNICEF, this is our key mandate. That's in terms of WASH. We have other activities we're also doing, but when it comes to WASH, these are our focus areas. I will just backtrack a bit. Before going into really providing the readiness activities for emergencies in communities at community level. I just wanted to highlight the fact that we always ensure that communities already have access to the basics, in terms of water, in terms of sanitation and hygiene. So our approach we are using would be the community engagement, doing the CLTS, which now we do the CLTS, integrated with the market-based sanitation, where we create demand and strengthen sanitation supply chains, and it's the same thing we're also now doing for water supply, because even for water now we are now working with the private sector so that we can also be able to create market demands for to be able to ensure sustainability of the services that are being provided. We're also incorporating the GESI, the gender equality and the social inclusion, making sure all our facilities are gender responsive, equity focused, empowering women, girls, and vulnerable populations so that, they will also be able to take the lead and participate. But most importantly, making sure, no one is left out, we leave no one behind. So we are also strengthening systems by working with government. I'll actually come to that in my next slide. And reinforcing sustainability, which I just mentioned, and of course, collaboration and partnerships. When it comes to emergencies, our key for UNICEF, our key partner has always been, government and the WHO, and of course, other partners that are also engaged in WASH emergency activities. Of course, for community level, we also try to do the financial inclusion, which I also mentioned, about bringing in the private sector. So in terms of strengthening the community level WASH preparedness and response, we focus so much on community mobilization, engaging the communities, so that especially, when it comes to the early stages of the emergencies, or even because we really want to ensure they are always engaged before the emergencies actually occur. And that is the reason why I had to backtrack a bit so that, I can also be able to, just give a background to how we engage the communities, even before the emergencies. Because if an emergency erupts when there are no facilities at all, or the facilities are not either they are not available, or if they are available but they are not properly maintained, then we will still be in a problem. We will still be in a crisis. So we always want to be sure the facilities are there, and they are all functional in workable conditions. And of course, the stakeholder engagements. I just spoke about, the partnerships, the coordinations, the collaborations. So, that's where we work with other sector partners, mostly the WHO, the government, so that, we review contingency plans. If the contingency plans are available, like we always do for Ebola, for cholera, we did the same thing for COVID, we did for mpox and others. Every time there are emergencies, we want to go back to those, have a review of those, of those contingency documents, or even strategy documents that are available, so that we make sure, we are not taken off guard. And of course, as soon as we hear about a potential, threats of a potential emergency, the first thing we do is for WASH, in terms of WASH, the first thing we do is make sure we do prepositioning of WASH supplies. Well, sometimes we call them WASH NFIs, they could be buckets, they could be soap, they could be, anything, chlorine, they could be upper tabs for, drinking water at the household level. And of course, we also work with partners, those that are doing behavior change communication. And for UNICEF, we also have the risk communication and the community engagement. So we also work with them so that at least, because when it comes to, when emergencies erupt, mostly it is our RCC colleagues, that always go, engaging with communities to ensure, the emergency. The emergency doesn't spread. So if it's an outbreak, at least it can be contained, before it blows out. So we also make sure we provide access to services. Of course, the providing access to services will depend on the context. and the type of facilities we provide will also, like I said, depend on the context. So if it's like when we had Ebola, for instance, we made sure we go into the healthcare facilities, went to our ports of entry, at the border points, providing services there. Like at the border points, we will go, we provide soap, we provide water if there is no water there. We provide hand washing facilities, because it's very, very critical that people coming across the border are well screened. Mostly the screening is facilitated by the WHO and other, well, of course, the government itself. But UNICEF also will be there working with the partners on ground to make sure all that is done, and of course facilitating the disaster risk communication in those areas. So for healthcare facilities, I've already, as I spoke about the community, I had already made some reference to healthcare facilities. But I mean, I just want to also reiterate, some of those actions we take, for the healthcare facilities, making sure we have resilient infrastructure, water supply, sanitation, hygiene, and also including waste management facilities. We try to be sure we get all those in those communities. Before now, we will just provide any facility, but nowadays, the good thing is UNICEF is currently working with partners, to do an assessment of the WASH situation in healthcare facilities in Tanzania. That's something that is still at its inception, but still, well, actually, planned, and we have already progressed with that because we've already engaged with the National Bureau of Statistics and the Ministry of Health. So that is now ready to kick off. So we are doing all that, and of course, the infection prevention and control itself, which is really very, very key. Of course, we all know IPC, WASH IPC. I mean, IPC cannot happen without a very efficient, without very efficient WASH infrastructure. So, because for you to do IPC, you need water, you need sanitation infrastructure, you need all of those, to be in place so that you can really be able to do an effective infection prevention and control. So we do that so that at least we prevent healthcare associated or nosocomial infections. Also do capacity strengthening of the WASH IPC staff, WASH staff that will be there, but also capacity strengthening on WASH IPC to staff at the ports of entry or in the hospitals. So we provide those training. I just spoke earlier about stockpiling of equipment, which also includes the prepositioning. So even if it's in communities, we still try to preposition supplies. So in case the situation blows out, we can always be there and be able to supply facilities in good time. Of course, when it comes to hand washing, soap, alcohol-based hand rubs, and of course, one of the key, the PPEs, we always make sure, those ones are also part of our stock. And, in doing this, we engage with other partners, ensuring, who does what and where, and who has what supplies, because maybe the WHO, for instance, may have buckets but do not have soap. But UNICEF has soap, do not have buckets. So we can always be able to align with that, and especially also when it comes to PPEs, because when it comes between UNICEF and the WHO, we have common areas where we collaborate, so that at least we there are no overlaps in our intervention, because overlaps only lead to losses. So in terms of waste management, we do, of course, the waste segregation. Also plan for transportation and the treatment of or the disposal. So in what we did here, I mean, like we also did in Sierra Leone and Liberia, we built, for in terms of waste, we constructed incinerators, placenta pits, ash pits, also, provided facilities for, collection and segregation of the waste that is being generated. In terms of technical tools, those are our reference points. The previous speakers have spoken extensively about, the wash feeds and the wash hero. So I will just skip that, because I think they have already done justice to that, So, and thanks so much to Mahmoud and the other previous speaker. And then we do cross-sectoral collaborations, which I already highlighted earlier. And as part of the cross-sectoral collaboration, we bring in other sectors that are not entirely WASH, but could also be able to contribute to WASH. I just mentioned, the WASH. I just mentioned the RCCE, and of course, the case management. That case management actually is already part of, the sector. But when it comes to mental health and psychosocial support, we have our colleagues, mostly from the protection, who support with this, because every time there are emergencies, we need to work with people so that we can be able, to work with them on their psychosocial, so give them some psychosocial and psychosocial support. And of course, for UNICEF, one thing that is really very much important is the prevention of sexual exploitation and abuse in all cases. It's really very important, because most of the time when there are, those emergencies, we see, a whole lot of things happening, either amongst the affected or even staff that will be providing service. So we always want to incorporate that as part of our intervention. And of course, we have also made sure we include we include WASH as part of WASH in healthcare facilities, in the WASH sector strategic plan for 2021-2026, and also part of, all the key policy documents. We made sure that is included. So this one is just, this slide is just talking about the importance of IPC and WASH, in emergencies, because we all know, of course, this one goes without saying, this is something we all know in terms of the importance of water, for drinking, for cleaning, for medical procedures, the importance of sanitation, these ones are all, quite straightforward. So, and of course, waste management, I was talking about also waste management, making sure the environment is clean, and of course, hand hygiene. And when we talk about hand hygiene, there are also some other hygiene actions we take, providing services for decontamination or or disinfection. So those are all part of activities we do. So when we provide our WASH facilities, we do this based on 4 key considerations: making sure the facility we provide is functional, that is, it's in good workable condition and it's working, works all year round. We don't want a facility that works today, not working tomorrow, especially, when we have a complex emergency. We have to be sure all facilities are functional and they are able to serve everyone at all times. And also the quality, meeting the required standards. Latrines that they provide safety for. They provide safety and are able to separate human waste from human contact. They provide privacy and security, because that's also very important. I think I just mentioned the issue of the PSEA, and for us to really be able to get that right, we need to have facilities available, where it provides privacy and it also provides security, especially for women and girls. Please don't mind me, I'm from UNICEF. So, and of course, the issue about, we mark the facilities, making sure they are quite separate, they are separated, for males and females, and in some situations and in most situations, actually providing services for menstrual health and hygiene, and also have trained staff to manage the facilities. In terms of accessibility, we ensure the facilities are accessible to people at all times, including persons with disabilities, and are accessible, to all, regardless of gender, regardless of your situation or your status. And of course, we also, when we design our WASH infrastructure, sometimes when it becomes very, very urgent, we may not be able to meet all this. But as the emergency progresses, we make sure we provide facilities, that have non-slip floors. They have signages, they have handrails, for people with disabilities, and also have grab rails. They have ramps, so they can be able to. They can be used, by all. And of course, the quantity, ensuring we have sufficient facilities to meet the needs of the wider population. So now I will just touch briefly on the practical steps for WASH, for WASH in healthcare facilities, and I'll just these are activities, some that are taken jointly, some that are taken specifically by either UNICEF or the WHO. Like the issue of conducting the situation analysis. This is something that is done well from the UNICEF side. We do it on our own, but generally when we collaborate, this is something that is done collaboratively, and most of the activities are actually done collaboratively, because even when it comes to the development of the health workforce, which is mostly done by WHO, we also collaborate, when it comes to that, because we also from the UNICEF side, we also train healthcare workers on IPC. So these are all things we do, conducting the situation analysis, setting targets, and defining roadmaps, through collaborative efforts, establishing national standards. Of course, the national standards are always there. They keep being updated. And of course, we also have the global standards, like one that is, like the WASH Hero Care, the other global standards that we are using for WASH IPC and all of this. So now, in terms of our implementation, we follow a pathway, and the pathway is based on all the 5 components of providing water, providing sanitation, hand hygiene, medical waste management, and environmental cleaning. And these are done through collaborative efforts with the Ministry of the government, mostly the Ministry of Health, the partners. We have the WHO, also we have the private sector. Most of the time we find the private sector either doing water trucking, or providing some other services, or even providing supplies, because in most of the situations when we don't have chlorine, because sometimes chlorine have to be shipped from foreign countries, but we have a private sector partner that can easily be able to bring them in. We work with those private sector partners so that they can be able to supply the chlorine for us. And of course, we follow, we work based on some strategic areas in terms of governance, capacity development. I already mentioned that earlier. Strengthening our WASH monitoring and planning, IPC practices and behaviors. And one thing that is mostly left out, but one that really drives our implementation, is the budget and financing for WASH. So most of the time it is left out. When we plan, but then when we come now to doing the climax of a planning, that's when we start thinking now, how much do we need, to get this done? So it's also very, very important. And of course, that leads to some key strategic outputs. And of course, we can, so that we can be able to achieve the desired health outcomes of reducing, of a reduced healthcare associated infections and increasing, so when the facilities or when the population has access to quality healthcare, they tend to develop trust in the health services. And of course, we'll have a healthier community with reduced maternal and newborn deaths and reduced WASH-related infections, of course, linked to the earlier one. So I just decided to bring in something, based on what we had done with, for the Ebola. So this is just a framework that was developed by UNICEF. I just mentioned, remember, about, intervention at the ports of entry. So where, for instance, because most of the time, when we hear about, when we respond to emergencies in Tanzania, most of the time we hear, there are cases of Ebola, for instance, in DRC or in Uganda or what have you, so when we hear those information, the first thing we do is, the first trigger is, just go in, try to work with the ports of entry so that, we draw a line to prevent the infection actually getting into the country. And of course, whilst we are doing that, we'll also be working with, the general populations. We'll also be working with the general population, where, we do our RCC and health promotion. And at the same time, planning for, planning and capacitating the healthcare facilities so that in case they start receiving cases, they will be well prepared to handle those cases. The interventions we carry out in all these have already been highlighted, so I don't want to bore you again with that because I've already highlighted in my previous slides. So these are examples of some WASH infrastructure we have provided with the climate resilient water supply you see here, and then of course you have the incinerator and the washrooms, of course the latrines and the hand washing bay. But of course we do hand washing bays and we also do laundry bays for for people that get because if people get they have to stay around, so they will be washing their stuff. So some key messages. Hand hygiene, we all know, is essential to prevent for preventing infections. We have to ensure safe use of personal protection equipment, the PPEs, especially in confirmed outbreaks. So I mean, because I remember in Sierra Leone we had situations where, and by the way, colleagues, I'm also from Sierra Leone, and during the Ebola in Sierra Leone, we lost healthcare workers. We lost so many healthcare workers, and it was all because some of them did not have access to PPEs because when the Ebola struck, the health system was really like unprepared, for lack of a better word, so it created, a whole lot of, that's when we really, or as a country, we really realized the gaps in the country, so, in our healthcare system. So that's really very important. Of course, we also need to strengthen the contamination and the disinfection. And that's also another area where we had, the country had significant challenges in terms of, especially when it comes to disinfections, because there are even stories of situations where they were disinfecting people. Once there is a suspected case that is being taken to the hospital, they drop that person in an ambulance and just spray that person with chlorine, which was really out of place. But that's those I mean those are just some stories that happened. So something we really have to be very, very careful about, because some of those people that got sprayed with the chlorine, some of them ended up losing their lives. Not because of the Ebola now, but because of the way they were handled. And some key recommendations we just need to foster, and previous speakers have also spoken about the partnerships. We really need to strengthen our partnerships, and also leverage local knowledge and existing systems for participatory risk assessment, strengthen our capacities, of our WASH and health teams. We need to be able to adhere to and also implement the minimum standards. Either it's by following the WASH Hero Cape, or following just the standards, all the standards we have, and strengthening health information systems, because we really need to be very clear as to who we are reaching, and if there are gaps. Improving financing mechanisms for sustainability, also developing robust sustainability action plans, and institutionalizing WASH within national health systems through policy standards and roadmaps. And most importantly, actually for Tanzania, that is what we keep doing. As I speak, there is already a national healthcare emergency preparedness strategy that is being reviewed as I speak. So these are things we always do. So once those are done, we hear about things. We always develop contingency plans, and where they exist, we want to keep them updated. So with that, I want to thank you, and over to you. Thank you so much.
Yeah, thank you very much, James, for that beautiful presentation. That was a very thoughtful one. Because of our time, we would like to round up the webinar at 2 p.m. West African time. We still have one more speaker. And our last speaker for the day, the last but not the least, Dr. Damilola Adeniyi will be speaking on strategies to integrate IPC and WASH into health emergency preparedness and response plans, policies, and programs in Africa. I'll be reading his bio briefly. Dr. Odami Adeniyi is a Lagos-based public health professional and infection control consultant at the Center for Infection Control and Patient Safety, with competency in project management, policy formulation, training, curriculum development, and leadership development. He also serves as the Infection Control African Network West Africa Hub Training Coordinator. Dr. Adeniyi coordinated the pilot of the novel US CDC Environmental Cleaning Program Toolkit at the Lagos University Teaching Hospital in 2021, aimed at implementing cleaning best practices within LIMCS. He worked on environmental cleaning, and the toolkit pilot has led to presentations on multiple platforms such as the ICANN Conference, Infection Control Society of Southern Africa, and communities of practice within the United States, Canada, and Brazil, among others. Dr. Adeniyi has set up multiple IPC programs and facilitated several IPC training for both public and private institutions, such as the Nigerian Center for Disease Control and Prevention, NCDC, Lagos State Ministry of Health, KAAF Medical Laboratory and Maternity Center, Luke's Dental Clinics, amongst others. His commitment to improve IPC practice in Nigeria has led to his participation in validating the National Patient Safety and Care Quality Policy and Strategy and legal needs assessment for IPC legal framework development in Nigeria, among other IPC guidelines. Thank you very much for joining us today, Dr. Adeniyi. You now have the floor.
Thank you very much. Thank you to the GET team for the excellent work and inviting me to speak. And I must also acknowledge previous speakers for the excellent work. Dr. Mahmoud and Noshin, and also James Conrad. Good afternoon or good morning, depending on where you're joining from. I'll be speaking on integrating IPC and WASH into health emergency preparedness and response in Africa. Because I'm sure we'll all agree that we have been loaded with a lot of material regarding this topic. So what I would do is just to zero in on the aspects that help to transfer policy into practice. This is the outline I'm making use of. I would give a brief introduction. We'll look at why the integration of IPC and WASH matters. We'll look at the African context briefly. What do we mean by integration? And then we'll go into the different strategies for this integration, which include policy and planning, integration, joint risk assessment, health facility readiness, health workforce and such capacity, and then financial and supply chain. And then we just conclude with the key messages. All right, so this is an introductory slide. Just tries to define IPC and then WASH, which I'm pretty sure that we are familiar with. But I'll just suffice to say that IPC and WASH are critical enablers of safe and scalable high-quality health service delivery across all phases of public health and emergency. The bottom line is, if we're talking about emergency preparedness, it is impossible to have the necessary response required to deal with emergencies if we don't have IPC and WASH available as systems prior to such emergencies. And so typically during public health emergencies, because of the increased need for service, there's a lot of strain on existing systems. And so when we don't have IPC and WASH structures in place, it becomes a big challenge. And so this underlies the importance of this topic. And so reinforcing IPC and WASH capacities will be very, very critical to maintain continuum of care, enabling safe clinical scale-up and mitigating some of the challenges that we're faced with during outbreaks. In our context, particularly in LMICs, this even becomes more critical. And just like you have heard from previous speakers, the data globally around some of the WASH gaps, and then specifically within Africa, this integration becomes very critical in humanitarian settings where IPC and WASH systems are often lacking, and LMICs are an example of such settings. Just by virtue of some statistics by the Joint Monitoring Program of UNICEF and the WHO, this has already been touched on, so I would skip this. But I will just, highlight here that health emergencies tend to expose systemic weakness. Health emergencies don't create new problems. What those emergencies usually do is to expose, what already exists prior to those emergencies. And so if we look at different countries within Africa, where we've had outbreaks, whether it's Ebola or COVID-19 or cholera, just like I think it was James that highlighted, cholera and in herself. When we have these outbreaks, weak IPC and WASH usually are consistent, have consistently driven healthcare workers' infection and facility-based transmission. So the outbreaks themselves do not create problems. Usually what happens is that those outbreaks reveal the existing problems. And so when IPC and WASH are treated separately, what often happens is that the systems collapse under the pressure of those emergencies. And so then you'd have a lot of healthcare workers being infected, like we often see in cases like Lassa fever. And then the facilities that are supposed to contain those outbreaks sometimes end up being the facilitators of the outbreak, even into the community. And so the lesson is the fragmented approach towards IPC and WASH in a lot of healthcare facilities, leads to a failure to respond adequately when we have emergencies. And then chaos usually erupts. So integrating systems is very critical to saving lives and to sustaining the trust of the populace in the healthcare services that we have to offer. Looking at the African context, we still have a lot of gaps in emergency preparedness. In many African settings, emergency preparedness plans don't exist. And then in some settings where we have preparedness plans, IPC and WASH are often poorly operationalized. And so for a lot of people, it's an afterthought. You have an emergency and then people are running, helter-skelter, trying to sort the issues around having running water, proper sanitation, an IPC program and things like that. So for example, during COVID-19, isolation centers were established very quickly, even in Nigeria, but a number of facilities across the continent lacked basic water, all right? Basic water requirements at the GMP, sanitation, waste management was a challenge in some of those facilities. So what we have is not a knowledge gap. In a lot of African countries, it is more of a systems integration gap. And that underlies the importance of what we are looking at. So emergency plans usually are not the problem, but operationalizing those plans becomes a challenge because of the lack of practical IPC and WASH components. And then when you don't have these facilities in place, when you have outbreaks and then you have a surge, the capacity of the facility is usually a major challenge. So it's critical, for us to speak about integration. And when we say integration, what do we mean? What we're saying is beyond coordination, there should be joint planning. This is very important. The strategy I'm going to focus on, or the 5 strategies that I've highlighted, just try to show us how to integrate IPC and WASH into the existing systems, and how that forms the foundation for responses. So when we talk about integration, we're talking about joint planning, not having IPC teams or WASH teams working parallelly, but ensuring that they're communicating, working together, and in some cases the possibility of having both IPC and WASH teams together in one. When we talk about integration, we're talking about shared risk assessments. We're talking about linked financing and accountability, embedding IPC and WASH across all emergency phases. And of course, we already touched on the steps when it comes to emergency response, from preparedness to readiness, and then to response itself. So let's look at those strategies. The first one I would highlight is what I've called policy and planning integration. Now, integration must start at the policy and planning level. For a lot of facilities or in a lot of countries, what you have is a lot of siloed programs. WASH is done separately, IPC is done separately, and then you have the public health team, working separately and all of that. Integration must start at the policy and planning level. And by that, we mean IPC and WASH should be explicitly embedded within the national emergency preparedness plans and incident management systems. Now, in quite a number of countries, that is already the case, which is encouraging. One of the things we observe also is during the Ebola preparedness in West Africa, countries that embedded IPC expertise within their emergency operations centers tended to respond better and to be more effective, when it came to the time of handling, the outbreak. And, the Ebola virus, despite the morbidity and mortality, that came from that, presented a learning curve for a lot of facilities. So, for example, some of the African countries that have been recognized for their strong preparedness and their effective response to COVID early 2020, late 2019, early 2020. And this includes countries like Senegal, Nigeria, South Africa. These are actually countries that, particularly Nigeria and Senegal, that had learned lessons from 2014 when the Ebola outbreak happened. And so, for example, the preparedness team was already constituted nationally from January of 2020 in Nigeria, and that aided the response to the COVID-19 pandemic. So it's critical to integrate IPC and WASH into the national emergency preparedness and response plans. And if you notice, a lot of the WHO documents, guidelines and all of that, that is the trust of a lot of those documents. It's also critical to define clear IPC and WASH rules, during emergencies, and then aligning IPC and WASH policies with disaster and outbreak frameworks. The bottom line is there needs to be integration at policy and planning level. Like I already highlighted, the countries with Ebola preparedness plans that embedded this integration responded faster and better during the outbreak. The second strategy is joint risk assessment. And now a lot of tools have been highlighted in the course of this webinar. And so the point is, it's important to plan together, using shared evidence. We've talked about the IPC and WASH Cape tool by WHO, talked about the WASH feed, talked about the ECAP. There are several assessment tools. And so it is critical before outbreaks happen that some form of risk assessment is done across board. All right, so the need to assess water availability within the healthcare facilities, for example, sanitation capacity, the waste management system, environmental cleaning, hand hygiene, and then using the results of this assessment to guide emergency investments. And the reason why this is important is, again, we know that if facilities begin to try to respond to outbreaks, at the time the outbreak shows up, most times it's already too late. And so when we have risk assessments that have been done ahead of time, and then we have the results that can inform development of plans, it helps in guiding future emergency investments, meaning invariably such facilities will be better prepared to deal with emergencies. So an outbreak risk assessment that ignores water availability, some of the basic WASH components, it's pretty much, will not be effective. And then in cholera-prone areas, facilities that have conducted integrated readiness assessments were able to scale up faster during the emergency. So the key message here is it's important to have joint risk assessment instead of having them also siloed. The health facilities are usually at the front line of emergency responses. And so health facility readiness is very critical. And here we're focusing on infrastructure and the availability of necessary supplies. So health facilities are where transmission is either amplified or prevented. And the goal is for it to be prevented. Unfortunately, in most cases, they end up being amplified because those health facilities are not, ready. And so there should be a minimum IPC WASH package in place before emergencies occur. Again, statistics shows that during the Ebola response, facility that had established IPC infrastructure had lower healthcare workers being infected. And so, your WASH infrastructure is very, very critical. So policy and planning integration, joint risk assessment, and then ensuring that the healthcare facilities are ready, as far as infrastructure is concerned. So the system is already in place. And I think it's also important to highlight here that one of the things that we notice when outbreaks happen is when the typical response is to begin to run helter-skelter and then pump a lot of money into getting supplies that are needed in facilities or contexts where those supplies were not previously in use. The healthcare workers usually have not familiarized themselves with the use of those facilities or those supplies. And so it's not just about providing them during emergencies. It's also about having the infrastructure in place such that the healthcare workers who are supposed to respond have already familiarized themselves with the use of these equipments and then the various supplies. The fourth strategy is workforce and surge capacity. And this focuses on developing capacity, so capacity building and training, but not just training again, like we have, sometimes trainings happening in a siloed system, but having a cross-training model for both IPC and WASH focal persons. There are some facilities that have collapsed their IPC and WASH teams into one, such that those, both those involved in IPC and those involved in WASH, are being trained, simultaneously. And so it's also important to simulate emergency drills so that, the healthcare workers are prepared ahead of time. They know how to respond. And so the message here is that infrastructure alone is not enough. People are the ones that make systems work. What we also notice is that in the context of a lot of outbreaks in Africa, the healthcare workers that are often neglected include people like those that handle your waste and the cleaners, and they often tend to be the most exposed and unfortunately the least trained, and usually that translates into disaster and sometimes mortality. And so it's very important to have a mindset where we're training healthcare workers, not just the frontline healthcare workers, but also support staff and ancillary staff across board. So true integration ensures that every cadre understands their role in emergency IPC and WASH, and a part of that training should be emergency drills that will prepare the healthcare workers for possible outbreaks. The fifth and final strategy I would highlight for the sake of time focuses on financing. I'm sure we know the popular saying, follow the money. This is very critical. What we've noticed in a lot of healthcare facilities, the common response is that whenever there's an outbreak, and funds are released from donor agencies, NGOs, and sometimes government agencies. But when that happens during an emergency or at the beginning, during an outbreak, or at the beginning of an outbreak, that in itself, introduces a number of challenges, which will include, ensuring that you have the appropriate, supplies, being provided, the equipment that are necessary. And then there's also the question of whether the healthcare workers are even familiar with these equipment. So there has to be consistent funding. There has to be a dedicated budget that ensures that IPC and WASH infrastructure is available, integrating payment of your PPEs, hand hygiene supplies, environmental cleaning, waste management, and all of that should be in place. The message here is that if WASH and IPC are not budgeted for, there is no way that they will be implemented. And then we know that during COVID-19, African countries that supported the local production, for example, of alcohol-based hand rub, were able to respond, better because the local production of ABHR improved supply availability when the global supply chain failed. I think if we cast our minds to 2020, a lot of us will remember that sometimes the supplies, were not enough. And so facilities that already had, a system, a budgeting system, and were able to locally produce those supplies were at an advantage. So it's critical to have proper financing. There should be a proper budget, and the absence of locally relevant IPC and WASH equipment and supplies prior to emergencies usually will make it difficult for healthcare workers to be able to utilize these equipment when they suddenly show up during outbreaks. Just to summarize the points, strategy I've highlighted, policy and planning integration is key before the outbreak show up, ensuring that, IPC and WASH people are talking, having conversations, and then having guidelines, that, already show you how to integrate IPC and WASH in emergency responses. And so a lot of the work that the WHO is doing within itself, attests to the importance of this. Having joint risk assessments as against, what we have, where you have a lot of siloed assessments is also critical. Ensuring that our healthcare facilities are ready, because those facilities are usually at the forefront of emergency response. Ensuring that all cadre of staff, including the cleaners, waste handlers, have been trained, adequately, and making sure that there are emergency drills during trainings before outbreaks happen. And then a steady budget when it comes to finances for IPC materials and WASH materials, particularly the ones that encourage local production, is very critical. Okay, so for the sake of time, I'll just skip this. And then in conclusion, the key message is very simple. IPC and WASH are not optional during emergencies. And the strength of our preparedness determines the effectiveness of our response and ultimately how many lives are protected. And this slide just tries to give a bit of an illustration. If WASH is the hardware that is needed, and think of your hardware as your computer, your mouse, in delivering this webinar, for example, it's impossible to do so without my internet modem, without my laptop, without my mouse, the charger, and all of that. Then that would represent your WASH infrastructure. And then the software, every software I'm using right now, which includes the background operating system, the Zoom apps, PowerPoint presentation, every software used in delivering this session is akin to the infection prevention and controls system that should be available in every facility, healthcare facility. Without the hardware of WASH and the software of IPC, it is impossible to have proper emergency response. And so that would be akin to trying to meet a workplace deadline without you having your system and without having the proper software. And so integration must be deliberate, must be funded, and it must be a concerted effort. And Africa health security depends on strengthening our systems before the emergencies happen, not after. These are some of my references. Thank you for listening. I'm happy to take questions.
Thank you so very much for that beautiful presentation. And we sincerely apologize to our participants for taking extra so a few minutes out of your time. We'll be rounding up now and we won't be able to take questions. The questions can be attended to by the speakers in the Q&A section. And Dr. Adeni, I think there's a question for you. So we've come to the end of today's webinar, and I would like to sincerely thank our speakers for staying through. Thank you for sharing your time, your expertise, and the real-world experiences. We truly do appreciate you. And to our participants, thank you so much. So this discussion has clearly shown that IPC and WASH are not an optional add-on, but they are fundamental elements of health, emergency preparedness, and response. We've heard from our speakers, and I would like to note that the presentation slides will be shared with the permission of our speakers to all registered participants, alongside the certificate of participation. And on behalf of the Global Emerging Pathogens Treatment Consortium, GET, I would like to thank all our participants for joining us for contributing to this impactful discussion. And we hope the session has really impacted you and you can take back ideas to your various institutions and communities. And in light of this, we have the Get Newsletter Volume 24, also focusing on this same topic, and we are open to contributions. So if you want to write anything specifically related to this particular topic, strengthen infection prevention and control, and WASH for health emergency and preparedness, please reach out, send your article to omowumi at getafrica.org. Getafrica.org. It will be pasted in the chat box. Send your contributions to omowumi at getafrica.org. Thank you once again for your time. We truly appreciate you. The recording of this webinar will be uploaded on our YouTube channel at Get Africa on YouTube, and the certificate of participation will be shared to all registered participants. Please continue to engage with us on our social media platforms at Get Consortium and our website at www.getafrica.org. Thank you again for your time and participation. Thank you, and have a wonderful day. Bye. Thank you for joining. You can follow us on social media at Get Consortium. Thank you. A big thank you to our speakers too.